Dr. Oleg Zaslavsky is an associate professor in the School of Nursing, Department of Biobehavioral Nursing and Health Informatics, and director of the Digital Health Innovation Hub at the University of Washington. His work focuses on leveraging digital health to enhance care, particularly for older adults and those with cognitive challenges. He develops accessible digital solutions aimed at improving the well-being of these populations and their caregivers, and his federally and foundation-funded research emphasizes the creation of digital interventions that support fulfilling lives amidst age-related challenges driven by the belief that older adults can lead empowered lives. Dr. Zaslavsky has a commitment to advancing user-friendly, evidence-based digital health tools tailored to the unique needs of aging individuals and their care partners, and he actually has a very unique ability to share this complex technological information in a way that really facilitates integrating this knowledge in the lives of older adults for all of us. So welcome, Dr. Zaslavsky.
Thank you, Dr. Cochrane, for such a generous introduction and for the opportunity to present and talk to you about this important topic. I'm very, very thrilled to spend with you next 90 minutes. Today, I would like to talk about technology and AI in aging care, and more specifically, how this tool may support age-friendly care within the primary care and integrated healthcare system. As Dr. Cochrane mentioned, my own work sits in the intersection of aging, digital health, and clinical care delivery. Our group develops and evaluates digital tool designed to support older adults and their care partners. That include things like remote monitoring program, and I will bring up a few examples from my own lab in this talk. Digital behavioral intervention and increasingly AI enhanced approaches to help clinicians make a sense of complex health data. But I want also to set the expectation right away. The goal of today's talk is not to turn everyone into AI expert. That would be unrealistic and frankly not that necessary. What I do hope is that by the end of our time together, you will feel a bit more comfortable thinking through these 4 practical questions. First, what kind of AI technology already showing up in a clinical care? Second, what is likely coming next? Third, how can clinicians evaluate this tool safely and more importantly, thoughtfully? And maybe most important, how do these tools fit within the age-friendly health system framework, the same framework 4 M's that Dr. Cochrane brought up in the introductory slide. Because ultimately the key question is not whether AI is impressive. The question is whether it actually helps us care for older adults better. Let me start moving slides. So by the end of this session, I hope you will be able to do 4 things. First, I hope you will be able to recognize the kind of AI technologies that already be showing up in a geriatric care. Some of them may already be embedded in the system you use, even without being very explicitly labeled as AI. Second, I want us to think in a balanced way about both the benefits and risk. AI is powerful, but it also raises very real questions around bias, privacy, safety, transparency, and clinical accountability. Third, I will connect AI tools directly to this 4M age-friendly care model, what matters, medication, mentation, and mobility. So I will explicitly focus on these 4 domains. And finally, I want to keep this grounded in a clinical practice. As the as a registered nurse in the background, I do appreciate opportunities to ground it in a clinical care. Technology discussion can become abstract very quickly. So through the talk, I use practical example of how this tool may support clinician caring for older adults in a real world setting. So let's begin with a broader context, and maybe this will be a bit of preaching to the choir. But the reason AI is entering conversation about aging in many ways is quite simple. We are living through a major demographic shift. Healthcare systems are caring for more older adults than ever before, and thus adults are living longer with much more complex healthcare needs. Many of patients we see in clinical care are not dealing with just one chronic health condition. They are managing several at once. Imagine a fairly typical 82 years old patient in a primary care. That person might be living with a hypertension, diabetes, osteoarthritis, mild cognitive impairment, and maybe even early frailty. And none of these conditions exist in isolation. They interact with one another, they affect one another. Medication given for one condition might worsen another, and function decline increases the difficulty of self-management. So as you can see, it's very complex clinical scenario. And cognitive changes might also affect the adherence to medication or to the self-management plan, and decision-making becomes much more nuanced and might involve care partners and might involve a much more complex ecosystem. At the same time, we are facing major workforce shortage, especially in geriatrics. In many regions, there are simply not enough geriatric specialists to meet current or projected needs. So when people talk about technology and AI in aging care, that's really the backdrop. Many older adults, more complexity, and limited workforce capacity. And the point is not that AI replaces clinician. It does not. But there is a hope that it might help extend clinical capacity, support the early recognition of risk, and help teams intervene more proactively. And again, I will, at this point, it sounds abstract, but I will also later in my talk bring up several examples how we enact some of these AI tools. And this is exactly the same slide that you saw on the Dr. Cochrane introduction, but and I will just briefly mention. But before talking about technology, I think it's important to anchor ourselves in what good geriatric care actually look like. Many of you familiar with the Age-Friendly Health System Initiative and 4M's a framework. So let me briefly just revisit 4M's. What matter reminds us to align care with the patient's goal and preferences. For one patient, what matters may be longevity. For another, it might be staying at home, avoiding hospitalization, continuing to garden, attending grandchild's wedding, or simply remaining able to walk independently to the dining room. So it's whatever matter is very personal and one size fits all tool might not always be effective in what's matter. Medication reminds us to prescribe carefully, minimize polypharmacy, and reduce medication-related harm, included prescribing cascades. That is particularly relevant in older adults, where the burden of medication can profoundly shape quality of life. And mentation includes dementia, delirium, depression, and broader cognitive and emotional well-being. And mobility focuses on maintaining function, preventing falls, and preserving independence. So as we go through the rest of the talk, I would like us to keep one question in mind. Does the technology support the 4M's, or does it distract from them? If a tool adds complexity but does not improve function, safety, quality of life, or goal concordant care, that probably does not belong to age-friendly care. So let's pause and ground discussion kind of in a very basic concept by what we mean by artificial intelligence. So make sure that we all on the same page when we use these terms. At its core, AI refers to a computer system that can perform tasks that normally require human intelligence. That means learning from data, recognizing patterns, making prediction, or helping support decision-making. For example, AI can analyze thousands of medical images and detect patterns linked with the disease, and can review large amount of electronic health record data to identify patients at high risk for hospitalization or high risk for any other adverse health event. It can detect subtle changes in speech, movement, or behavioral that may signal decline. One point I want to emphasize in healthcare, AI generally is not about replacing clinicians. And again, I want to make sure that we are reiterating that. It's about augmenting clinical decision-making. It's a tool to help us process large amount of information more efficiently and ideally more meaningfully. Again, I want to reiterate, it's a tool that amplify clinician decision-making and amplify clinician voices. So I often frame it this way: AI should not replace judgment, it should support better judgment. So type of AI used in AI healthcare. There are several large categories of AI that come up frequently in healthcare conversation, and that it helps to have the basic sense of what they mean. Machine learning refers to algorithms that learn patterns from data. Deep learning is more advanced form of machine learning, often used in imaging and speech application. Natural language process, or NLP, refers to the method that analyzes text or spoken language. That might include extracting information from clinical notes, caregiver narrative, or patient speech. And computer vision refers to analyzing visual data such as radiology images, skin lesion, movement video, or gait recording. Most of clinical tools we are seeing today rely on large data set and machine learning approaches. They look for patterns that might not be obvious to human observers, especially when the volume of information is too great for any individual clinician to process directly. So how does this work in practice? A machine learning tool is trained on a huge volume of data. It looks at large numbers of examples and learns to recognize patterns associated with a particular outcome. For instance, imagine a model trained on 50,000 patient records to examine which factors are associated with a hospital readmission. The model might learn that readmission risk affected not just diagnosis, but by combination of medication burden, prior hospitalization, mobility limitation, social vulnerability, or evidence of functional decline. In geriatrics, machine learning are increasingly explored for things like predicting falls, identifying frailty, detecting early cognitive changes, or flagging medication-related risks. And the key idea is that as models are exposed to more relevant or better quality data, they might become more accurate or more refined in how they estimate risk. Of course, it also depends on whether data are representative and clinically meaningful, which we will come back later. So data sources for AI. AI models need data, and they need a lot of data to ingest. And modern healthcare generates a huge, tremendous amount of data. Electronic health record capture diagnostics, medication, lab values, visit history, and utilization patterns. Variable capture heart rate, activity, sleep, and sometimes gait or physiological stress. Medical imaging gives anatomical and functional data. patient-reported outcomes and information about symptoms, mood, fatigue, quality of life, and the daily function. What is especially interesting and now is that AI systems are increasingly able to integrate multiple streams of data at once as a multi-domain AI modeling. And once you start combining clinical data with physiological data, behavioral data, and patient-reported data, you can begin to see patterns that might otherwise were hidden. This is one of the big promises of AI in aging care, not just more data, but better interpretation of data that's already being generated. So there's a huge repository of data that's being processed in real time to find meaningful patterns. So what are the digital health ecosystem? Many of you already working within the digital health ecosystem, whether you think of them as the digital health ecosystem or not. Telehealth expanded dramatically during the COVID pandemic. Wearable increasingly common. Like many of you might be wearing Oura Ring or have Apple Watch, it's Fitbit, Garmin, or any other wearable technology. Smart home technology are beginning to show up in the aging service, and remote monitoring program becoming more common for chronic disease management and slowly making its way into the Medicare reimbursement model. And the challenge, of course, is that tools generate large amount of information. Clinicians do not need more noise. They need better signals. This is where AI increasingly comes into the picture. It helps to transform raw data into the clinically meaningful information to see patterns, trends, anomalies that deserve attention, to sift through a huge volume and to filter through the huge volume of data and to extract meaningful features. So rather than simply telling us that a patient's daily step count has declined, for example, the AI-powered system might identify that the pattern is unusual for that individual. It might be associated with this increased risk on functional decline or acute illness. So case example, like let's make more concrete with a simple case study. Imagine older adults living at home with a heart failure. The patient uses smart scale and wearable devices, and each day the system captures weight change, heart rate, and maybe even physical activity levels. On any single day, these changes might not look dramatic, but over time, an AI model might detect a pattern suggesting fluid retention, reduced activity, or worsening physiological stability or physiological stability. That patterns triggered an alert to a clinical team, which might follow up with a quick call, a medication adjustment, or a sooner follow-up. The value here is not for any prediction on its own sake. The value is in the action plan or early intervention. So for all of that, specifically for those with a frailty or might be vulnerable to changes in physiological balance or with multiple chronic condition, preventing hospitalization can make a very meaningful difference in preserving baseline function, independence, and the quality of life, because a hospital environment might be often be toxic and leads to the cascade of downstream effects. Another concept that is getting increasing attention is the idea of a digital twin. A digital twin is the essential virtual model of a patient. It combines multiple sources of information, medical records, imaging sensors, and maybe even genetics to simulate how the person health might evolve over time. So it allows us to extend the exploration from in silico and from in vivo and in vitro to the often to in silico. Now this is still relatively early area, especially in clinical geriatrics, but the vision is compelling. In theory, the digital twin could help us model what may happen under different treatment strategy. So it might give us idea what effect the treatment or medication have on the specific person. For example, could we better anticipate functional decline after surgery? Could we estimate how a patient with heart disease or frailty might respond to one intervention versus another intervention? We are not yet using digital twins routinely in the everyday geriatric practice, but this concept illustrates where the field is heading toward more personalized, predictive models of care once we have more data coming, more high quality data coming from the individuals. So where is AI being explored in geriatric now, or in a near in the near future? Several areas stand out. There is a significant interest in early detection of dementia and cognitive decline, and I will feature some of our projects. There is also growing work on a full risk prediction and mobility assessment, frailty identification in another active area, and again, frailty prediction and management. So I'll also give a few examples from our ongoing projects. Medication optimization is also important, especially in the context of polypharmacy and adverse drug events. What many of these applications have in common is a change from the reactive care to more proactive care. Instead of waiting until full happen, hospitalization happens, or cognitive decline become obvious, the goal is to detect risk earlier or even intervene sooner. This is especially relevant in aging care, where timing matters so much. Early support can mean the difference between maintaining function or losing it. Again, because there is a sensitive period on when intervention matter, and that it can either slow down functional decline or even reverse it. So let's now connect to the four aims, and starting with imitation as a first domain, as a first use case. Imitation includes cognition, mood, and the broader processes that shape how older adults function day to day. AI tools may help us to identify cognitive decline earlier than traditional approaches alone. For example, speech analytics can sometimes pick up subtle language changes associated with early dementia. AI models analyzing MRI data can identify structural changes that are difficult to fully appreciate through the visual review alone, or behavioral monitoring system may detect changes in sleep, activity patterns, or routine that suggest early decline. And the potential value here is early recognition. And early recognition can support better planning, a more timely support for families, a more appropriate clinical follow-up. And of course, these tools are not replacement for careful clinical assessment, but they may become increasingly useful its own. In our work, and as I promised, I will feature a couple of our ongoing study. In our own work, we're specifically interested in speech as a potential marker of cognitive change in people with a moderate to severe dementia. And as you know, speech carries a remarkable or huge amount of information. It reflects language, memory, executive function, processing speed, and social engagement. And when cognition changes, speech often changes too. Especially, and you can look at these subtle changes in speech, even in people with a profound memory loss. loss. You can see here the changes in the structure. We look at the features such as word finding policies, how long it takes it takes individual to come up with a certain word, to replace a certain word that they are looking for lexical diversity, and like how often how often they use certain terms in their speech, and or a sentence complexity, and the features such as the coherence, to what extent the content focused on a specific theme or on a specific anchor, or kind of wander ramble around. So we can, with the AI tools and with the with AI techniques, we are able to investigate, or we'll be able to look to focus into this specific feature much more in much higher scale, and in a much higher details. And AI models can help identify patterns that might not be easy to quantify consistently by human judgment alone. And we often hear from the care partners or caregivers that their loved ones do like sound off, but it takes time to anchor that, like what exactly happened. So with AI tools, we can model that the change earlier, so it can recognize a potentially impending health crisis, or like in our work, we were looking for the early signs of delirium through changes in speech, which was often reported by the caregivers, but here, like, it would give us a more objective anchor by looking on the semantic and non-semantic changes in speech. And the reason this is exciting is the speech is relatively naturalistic. It can potentially provide a less burdensome window into cognitive function over time. So envision in the future, so we can have tool that can understand what that can give us the insight into the cognitive functions through speech. Another area where AI is gaining traction is mobility. And mobility is definitely foundational for older adults, and it affects independence, fall risk, social engagement, hospitalization risk, and definitely overall quality of life and well-being. AI-powered system can help monitor gait speed, balance, activity patterns, or subtle changes in movement that may indicate increased risks. Fall detection system can alert caregivers, smart walkers, or other assistive tools might provide feedback or stability. And robotics also increasingly explored in rehab and recovery. What is attractive about mobility-related AI is often focuses on function, which is so central to geriatrics. Preserving mobility, it's not just about preventing falls. It's about helping people continue to do what matters in daily life. And I wanted to feature, like in other projects, one example from our own work is vocali frailty projects that was recently funded through the National Institute of Aging R01, and we will launch this randomized control trial very soon. And the project is based on a simple premise: frailty is not static; it is dynamic. In many cases, it may be modifiable with with potential lifestyle changes and modifications. Vocali frailty is a remote psychoeducational intervention that helps participants engage with structured module around physical activity, nutrition, sleep, social engagement, and other health promoting behavior. So it's a moderated health platform that allow participants to anchor this discussion on this important topic that support their self-management and self-behavior. Participants reflect on their experiences, track progress, and build strategies over time by creating this virtual community of mutual support and sharing. But we also use the AI tools here to help us identify patterns in engagement and functional trajectory, because the platform generate a lot of content. They generate huge corpus of data. It's even though it's moderated by the human moderator, but the AI tools helps to filter or kind of to comb through this huge amount of data and identify meaningful patterns that might flag a action from the moderators, or might justify like some more personalized approach. What I like about this example is not just a passive monitoring; it's about proactive empowerment. The technology supports reflection, behavioral change, and early recognition of change that might matter clinically. And here it's AI is not replacing human moderation. It's amplify listening, and that's what matters most here, is to amplify listening and amplify a meaningful data extraction from the data. And the broader goal is to help people maintain function longer, yet potential slow the trajectory of decline. So let's move to medication. Medication safety is a major challenge in geriatric care. Polypharmacy is extremely common, and the risk of well-known adverse drug events, confusion, falls, hospitalization, functional decline. AI tools may help by analyzing medication list and identify risky combination or pattern that might suggest elevated health risk. Some system aims to predict adverse drug events. Other might help tailor dosing recommendation based on the patient characteristic, kidney function, or even prior response pattern. This tool can be especially useful when the clinical picture is complex and the number of interacting medication is high. But again, the goal is not automation for its own sake, but the goal is to help clinicians reduce medication-related harm and simplify care when possible. In another project from our own lab that might help with the medications and preventing this downward cascade of prescribing is our work focused on AI analysis of cough sound that might help detect pneumonia. So we're building a pneumonia classifier using cough. And the clinical logic behind it is fairly straightforward. If we can identify pneumonia earlier, especially in long-term care in community setting, we might be able to intervene earlier and avoid some hospitalization. And that matters because hospitalization can be harmful for frail old adults. Even a relatively short hospital stay can lead to deconditioning, delirium, sleep disruption, medication cascade, and loss on baseline function. So the early detection has potentially valuable. So in this project, we're collecting lung and cough sound from the large sample of all adults living in assisted living and memory care community, and it's in a close partnership with Kobe University in Japan. So we do a parallel work there, and by collecting large amount of high quality data that adjudicated healthcare outcomes such as pneumonia, like in the X-ray and antibiotic treatment. So we are hopeful that we will be able to train model that will help us to identify pneumonia early, even by analyzing cough. So in the future, and in near or further future, so we are hopeful that it will be similar to the urine dipstick that frontline clinicians you often use to screen for potentially harmful UTI or for the potentially consequential changes, but here we envisioned that we can use the smartphone in the same way to flag emerging health issues. Now let's connect technology to what matters. This domain is especially important because it reminds us that the goal is not simply better prediction, but more goal-aligned care. Technology can support this in a few ways. Some tools can track quality of life or function over time. Other help identify care patterns that are more consistent with the patient preferences. For example, if a patient values staying at home or avoiding hospitalization, digital monitoring tool may help teams intervene early in the home setting. If maintaining independence is the primary goal, then a system that helps detect mobility decline earlier might be directly aligned with what matters to that individual. So the question is always, does the tool support the person goal, or just generating more information without meaningfully alignment to care priorities? And here, like I would like to bring up like another example on our work with the Vocali Lewy body dementia, which supports caregiver of people with the Lewy body dementia. And we have another pending R1 from the National Institute for the Mental Health to further validate this psychobehavioral intervention in a larger randomized controlled trial. And just to give you in a nutshell, so caregivers and care partners participate in a remote asynchronous platforms where they reflect on daily challenges, decisions, strategies, and coping stress around coping strategies. So it's moderated health platform that allow caregivers to engage at the time and location when it's convenient to them. And we had a couple of pilots for this study, and often caregivers shared that it would be a highlight of their day where they caregiving duty allowed them that were able to connect with their support community, that were able to share and to share their experience and read about other experiences, learn more skills and acquiring like new problem solving strategies. We made sure that it's the platform is even though like it's a text-based platform, but it's fully accessible. We had if a legally blind person with the English second language who was fully engaged in the intervention, and I think like the person that benefited the most from the intervention, and we could see meaningful change in their well-being, like in their depressive symptoms, improve their caregiving burden, also improved over time. And again, the same as with the vocalic frailty that I mentioned earlier, we use the AI tools that help us analyze patterns across the caregiving narratives, because the moderator can focus on one or on that kind of cross-sectional, and that's a single point of time interaction that they can review their past interaction, but AI tools they can help to bring this all together and again amplify listening and amplify empowerment. What I find compelling here is that technology does not replace empathy. We are not outsourcing moderation. We are not outsourcing generated conversation. It does not replace empathy. It does not replace listening. Rather, it is scale listening. So it can augment moderation and help the moderator to work with the tandem in tandem with the technology. And that matters because caregiving often carries a tremendous burden, and caregiver burnout is strongly linked to the institutionalization, crisis driving care, and poor outcome for both caregiver and the patients. So supporting caregiver is not peripheral to geriatric care and central. In this case, AI can help us notice patterns and caregiving experience that might otherwise remain invisible until stress become unbearable and overwhelming. So one of the most consistent thing we hear from all the adults is actually very simple. Most people want to remain in their own homes for as long as possible. They want to stay connected to familiar routines, neighbors, communities, pets, kitchens, gardens, all the ordinary things that give life structure and meaning. And technology is increasingly being explored as a way to support that goal. For example, some homes now include unobtrusive sensors that track change in daily routines. If someone who typically gets up several times a night suddenly does not, or if activity levels change dramatically over a short period, that might signal that something is wrong. Again, they may flag some changes in pattern. Remote monitoring programs can also allow clinicians to track health without requiring repeated clinical visit. And some systems are beginning to identify signs of social isolation, which we know has real health consequences in later life. So the broader idea here is not surveillance for its own sake. It's about supporting independence while creating safety net around people who want to remain at home. Another area often generates a lot of curiosity is robotics. When people hear the word, they sometimes imagine a fully autonomous caregiver walking through the home. Unfortunately we are not, or fortunately we are not there yet, and I am not convinced that is even the right goal. But there are practical and emerging applications that are worth paying attention to. Some assistive robots, and I included some of the pictures here, may help remind individuals about medication or appointments. Others might help with the mobility transfer or simple rehab task. Some are designed more for social interaction, providing prompts, reminders, or opportunities for engagement. The reason robotics is attracting attention is partly clinical need and partly workforce realities. We know there is a growing shortage in geriatrics, and technology can support routine tasks might help extend human care. But I think that the framing also matter. The goal is not to replace clinicians, caregivers, or relationship. The goal is to augment care so that human time and attention can be focused where they are most needed. What are the potential benefits, kind of in reflecting on what I just mentioned earlier? One major benefit is the early detection. I definitely can see benefit, and then AI system may notice subtle physiological, behavioral, and linguistic changes before they are obvious in routine care. Again, an example from our analyzing speech, analyzing acoustic contours or acoustic features that otherwise might not be obvious by the human ear. So I think we can definitely can see benefits of AI to leverage signal processing and empowering a clinical system to detect changes earlier. Another is improved diagnostic support that might especially relevant in imaging, pattern recognition, or risk stratification across large data set. Electronic health records are common, and they generate huge amount of data. So combing through this records might help with the risk stratification. There is also possibility for more personalized care rather than applying the same intervention to everyone. We might be able to better tailor care based on a person's specific risk profile, functional status, and treatment goal. And perhaps most importantly, improved monitoring of chronic condition might allow early intervention, which in turn may prevent complication, emergency visits, and hospitalizations. And of course, these benefits are not automatic. They depend on careful design, meaningful validation, and implementation that actually fits clinical practice. I would be remiss if I wouldn't mention an important risk and limitation. And definitely at the same time, we need to be cautious about overselling what AI can do. And yeah, I think we're bombarded with the headlines that that AI can change and can replace and what. But I'm not AI hawk, but it's also I think we need to understand what reality is. There are very real limitation in concern. Data privacy is one. Many AI system depends on large volume of personal health data, and protecting that information is essential. Bias is another major concern. If the training data does not represent the population we care for, then the model might work well for some groups and poorly for others. So it might not be generalizable to everybody, and we need to look under the hood and understand what data we are working with, what data inform that model, and what data AI was trained on. And clinical validation certainly is a challenge. Some tools move into the market or into practice setting before there is enough evidence to support their use in diverse older adults population. So I think there is a race to embrace AI tools in a clinical care, but we do need to have a very clear validation strategies to understand what was included and what data it was trained on, like and strengths and limitation. And finally, there is a risk of over-reliance. If clinicians begin to treat algorithmic output as the inherently objective or correct, that can be dangerous. And again, there is a risk of either a descaling or a underscaling or never scaling. So it's important to work with the AI tools, but it's also understand their strength and limitation and being able to appraise them in a knowledgeable manner. AI should support thinking, but it should not replace thinking. Because of the risk, ethics really has to remain central to AI adoption. Patients should have a clear understanding of how their data being used and how technology is contributing to clinical decision making. Clinicians remain accountable for the outcomes. Even if algorithm generates recommendation, the responsibility for care still rests within the clinical team, and this is what clinicians need to understand well. So it's still they're still accountable for the outcome of the care. We also need to ask who benefits from this technology or who might be left behind. If a tool worked well only for people with high digital literacy, stable internet, or access to expensive devices, this might actually deepen disparity rather than reduce harm. And ultimately, none of this work without trust. A patient needs to trust that technology is being used in service of their care, not just because it's available or fashionable. And trust, it's definitely has been a sticking point, and we should pay special attention on how we build trustworthy relationship with the AI. And again, it's not a fab. It's a tool that can support better or that should support better care. And this brings us to the digital divide. Not all old adults have equal access to technology. Not all old adults have had equal opportunity to develop comfort using it. Some lack devices, some lack reliable internet. Others might have visual, hearing, motor, or cognitive challenge that make many current available tools difficult to use. And to be honest, a lot of health technology is still not designed for older adults in mind. Interfaces might be cluttered, instructions unclear, audio hard to hear, and workflows unnecessarily complicated. So if we are serious about using digital tools to improve aging care, then we also have to be serious about accessibility usability, affordability, and support. Technology can only improve care equitably if people can actually use it. And one of the strongest ways to address that problem is through co-design that we use for many of our projects, for Vocali Frailty and Vocali LBD and some other institution of Vocali. So we made sure that it was co-created with the end user in mind. Instead of building technology for all the adults and then testing whether they tolerate them, we should be building technology with all the adults from the very beginning. Nothing about us without us. That means involving all the adults in design, testing, feedback, and refinement. It also means including caregivers and clinicians because they often see barriers and opportunity that engineers or developer might miss. When users participate in a design process, tools tend to be more usable, more acceptable, and more likely to fit into real life. They sound obvious, but historically, a lot of healthcare technology have been built without enough meaningful input from the people who are expected to use. Many times it's innovation driven, and there is a hammer, and everything looks like a nail, but further down the line, they might learn that nail might have different form shapes and needs, and we pay for later and poor adoption. So if it was not customized from the very beginning, that may backfire later. Implementation challenges, even when technology is promising, implementation can be hard. A tool might work beautifully in a pilot study, but it does not integrate into electronic health record. It might not be used consistently. If it requires clinician to log into multiple platforms or into poorly explained output during busy clinic out, it becomes one or more burden rather than a support. And we learned the hard way when we have the best intention, the best tools, but when it does not play well with the electronic health record or with a tool that the clinician disposal, or they have good IT support for them, it might not be usable, it creates extra burden. And training matters, workflow fit matters, reimbursement matters, and leadership support matters. So innovation alone is not enough. Implementation strategies matter enormously. In many ways, this is where otherwise good ideas succeed or fail, not in the algorithm itself, but in whether the tools can function meaningfully within the real world care system. And that's I'm very pleased to see more RFP, more RFAs, request for proposal of application. They support pragmatic research, that happen in the real life, in realistic clinical system. So let's bring it back to a concrete example. So imagine an 85-year-old patient with a history of falls. Over the past year, the patient has fallen twice at home, no major fracture, thankfully, but each fall has increased anxiety and reduced confidence. So now imagine that an AI-powered tool that analyzes gait speed, measured during the clinical visit, the medication list, and documented fall history in a health record. Based on these patterns, it flags the patient is being at elevated risk for another fall. That alert does not make a decision, but it prompts clinician to take a closer look at flag this case. May there be sedating medication that can be reduced. Maybe orthostatic symptoms need to be explored. Maybe this is the right time to involve physical therapy, recommend balance training, or review home safety modifications. In this case, this tool is not replacing judgment. It's helping clinicians identify risk earlier or even intervene sooner. And that maps directly into the mobility domain in 4M models. So what are the guidelines that I would give to the clinicians that are in the audience? So how should clinicians approach AI tools? I think it helps to begin with a few basic but very important practical question. How the tool actually being validated and in what population? What type of data it uses? Could this data introduce bias or leave out key aspect of the patient experience? How transparent is the system about how it reaches its recommendation? And most importantly, does the output make clinical sense in the context of the person in front of you? AI can be useful, but it should always be interpreted alongside clinical expertise, patient preference, and situation context. Clinical judgment remains essential, and I often refer to this a pyramid of evidence that we spend quite a bit of time talking to our students, like where evidence is coming from and what are and what may be gaps in evidence. So what may be future direction? I think we are likely to see continued growth in several areas in the near future. One of them is digital biomarkers, signal derived from speech, movement, behavioral, sleep, physiology that may help us detect a disease early. So every data is a currency this day, and there is and there is an increased interest and understanding the data that it might have been discarded in the past, now turned into the important source of information, such as like in our study, cough data, or that allow meaningful signal processing, or lung sound data that can give us important information. Another increasingly personalized predictive model that integrates multiple sources of data and offer more tailored estimated risk of response, like the in silico model, where you can simulate different scenario, and again, digital twins concept that I brought up earlier. And more broadly, healthcare may continue shifting toward more anticipatory risk rather than reacting only after disease or decline become obvious. But the future direction of the field may depend not only on the technical innovation, it depends on how thoughtfully we evaluate, regulate, implement, and align these tools with real clinical needs. So let me briefly summarize. Artificial intelligence has real potential to improve aging care. It might help us detect disease earlier, personalize care more effectively, support aging in place, and identify changes before they become crisis. But technology should remain human-centered. It should support clinicians, not replace them. It should support all the adults and caregiver, not burden them. And it should be designed to implement in ways that are equitable, ethical, and aligned with what matter most to patients. If we keep this principle in view, then AI can become a meaningful part of age-friendly care rather than simply another layer of complexity. Ultimately, the goal of all this technology is actually very simple. It is to help older adults live healthier lives, maintain independence, and receive care that reflects what matters most to them. Thank you very much for your attention, and I would be happy to take any questions. And I also left my email so for any follow-up thought, comments, or reflections. And I will bring it back to you, Dr. Cochrane.
Thank you so much, Oleg. This was just great. I love what you said about we don't need more noise, we need better signals, because that certainly seems to fit. I'm wondering if you have thoughts or suggestions about how to, a little bit more about how to talk with older adults about AI as they're venturing into some of those opportunities.
Yeah, it's a great question. So, as a matter of fact, we had a pilot project within one of the retirement communities where we engaged them in a what we call AI literacy. And again, the idea is not to turn into the AI experts, but to give what we call AI fluency, better AI fluency. And what we envisioned, the hands-on experience in work best. So we gave high level information about what AI is and what AI is not, but but it also we engage them in the meaningful interaction. That was more about using some of the ChatGPT tools to understand like what's called like prompt engineering, like how to ask meaningful question and how to see interaction involves. We also looked into the opportunity to improve usability of some of the informational platform or that are common in this retirement community, how to make it more usable for them, how to help them to retrieve meaningful information from the from the legacy web pages where you need like to browse. But it's also what are the kind of guardrails that need to keep in mind, like what information you should or should not put into this large language models, like and what information that might get about you. So there was quite a bit of interest, and we had a fairly diverse audience that included a very naive users and a more experienced user, and we thought quite a bit of interest and quite a bit of improvement in the AI literacy skills. Dr. Gordon, you're on mute.
Keep doing that. Well, I've got this cold. I'm trying not to cough, too much. So I keep forgetting to turn it off. So Chandra is wondering if you could you expand on how digital biomarkers will be used in the future? Maybe an example?
Yeah, it's a good question. I can speak about vision for let's say like for one of our tools that we talked about this cough analytics or lung sound analytics, and I brought up examples. So what we felt if we can empower bedside clinicians or staff to have more tool at their disposal. Like as I brought example of the urine dipstick, when they experience urinary symptoms, so you can self-test or you can test for the patients if there are abnormal abnormal biomarkers, abnormal. So we envision, and everybody carries their smartphone, so we can do similar tests using a smartphone by recording a cough or recording some other signals that might come from the. So that's what I meant by digital biomarkers, like by exploring signals like either acoustic or like let's say like linguistic signals from the patient, so we can explore if they relate some meaningful changes in health. At this point, we collect data like for the cough study. So we collect data, we collect cough, we listen to their lung using digital stethoscope, and we extract ton of data from their electronic health records about their X-ray, about their oxygen level, about their health history, about their antibiotics treatment. So like by bringing this all together, so we can create a phenotype and the digital and digital biomarkers for the emerging health condition.
So Sheila is wondering if you could say a little bit more about what did the devices look like?
AI-powered devices. It's a good question, and smart devices and like let's say Apple Watch have a capacity to analyze huge amount of data, and I often see they featuring new analytics, but also I'm having a hard time understanding what is useful in this data and what create more noise. So I think again, like cross references with the what would be meaningful in geriatrics? So I would go back to this 4M model and see like what information is useful. For example, the gate stability, gate parameters, to what extent it matters in function, or a or some other. So I think devices, it's a broad category, and in many sense a it might incorporate some of the analytics, like even maybe predictive analytics, because when we talk to the AI, it's more about predictive analytics rather than generating kind of a monitoring what's happening at that time. So I think as we collect more data, so I think we will be moving more into the predictive analytics space.
Cheryl is wondering, and I don't know this device, but maybe you do, would the Dexcom G7 device be considered an AI device?
Well, it's quite specific. I don't have an answer for like categories and what features it has. So I again, like when with the
She said it's an insulin device.
Insulin device, again, like that doesn't have a predictive, like, is it monitoring in real time, but it's also can generate kind of predictive analytics, but I don't, it's probably on the FDA purview, like what is considered AI device, what is not considered AI device. So I'm less versed in the regulatory space.
Well, and then she mentions a wearable heart monitor, and I'm thinking about actually some of the pacemakers that are available, implantable pacemakers that are available too. To what extent those might be considered an AI device?
Well, I think like this we do look for smart. I think like there is a movement toward smarter devices, but I don't know like at what stage like the smarter devices turned into the AI devices, or kind of we have quite a bit of a spectrum.
Well, so I have an Apple Watch which analyzes my sleep during the night, but in the morning, what I get is a sort of a summary of my score and a little explanation of that score. That's not predictive, but it's certainly a summary that I wouldn't be able to come up with on my own.
Well, and I think like increasingly the devices generate multi-domain like data coming from the multiple sources. So like whether the sleep, it's about motion, it's about heart rate monitoring, it's about the microphone that might detect sound. So I think that's the device is becoming smarter, but it's also the question like how we turned it into the can it predict? Can it give you tailored recommendation or what to do next, or like how? Yeah. So I think for me, smartness is about processing, but it's also about the next step.
Thinking about that great signal, I'm wondering, just to kind of encourage some thought from your attendees. Perspective from your setting or from your discipline, what sorts of questions are you getting from clients or patients that come to you and they've got some sort of an app or some sort of a device that's giving them information and data, and they're getting really excited or really upset or something? What kinds of questions are you getting? Sinyi mentions a question is health equity, and what is this is while you're thinking about my question, folks, but said what is the barrier and what are the barriers and challenges of implementation of AI in rural health care for older adults? That's a great question.
Yeah, and this is a fantastic question, and that's something that we kept in mind. So, like for example, some of the intervention that we develop supported by the low bandwidth internet. That's because like some of the telehealth intervention are common, but needing higher bandwidth for the synchronous session by the video. And what we found more useful is to use whatever infrastructure is available in that setting, and how to support the people where they are with the technology they have at their disposal. And so that's non-reliable internet or harder to reach areas. It's a real concern, and what tools or access to the primary care. So again, like some of the recommendations or some of the suggestions that they come from their peers might be more tailored to their needs than some generic recommendation from the from health provider in the urban setting. So we found that this kind of, by creating this community of mutual support and supporting people where they are with the technology needs and access that they have, or is meaningful. Yeah. So and it might be rural health, or from even frontier communities that might have a very limited access to, and just referring to the primary care clinician or saying the specialist might mean different things in rural setting versus in the in somebody that live in greater Seattle area.
Well, and so that's an important consideration, is who is getting the signal, and do they know what to do with it? and do they have the expertise to sort of interpret it and act appropriately?
Yeah, and another point that I wanted to bring, like it's many times about trust, and trust is built over time, and again in the rural area, like as Dr. Kern said, like who receives signals. So like what it means to receive a note that somebody decompensated, like and just to kind of refresh. So the trusts have three main domains. Like first one is like benevolence. To what extent do you believe the technology work in your best interest? To what extent do you believe that this tool have your best interest in mind, or their main purpose is to engage you in conversation versus giving it to you accurate information? The second one is integrity. To what extent you believe this tool is transparent, you understand what strengths and limitation, and the last was the ability. To what extent you believe that that it have a capacity to, or they have a skills to improve your health. So I think like even in rural settings, the set of benevolence, integrity, and ability might look different. So again, like I said, and many times, like what we learn, that all the users don't engage with the technology for the sake of innovation, but for the sake of getting a tangible tangible tools to improve their 4Ms. So I just wanted to refresh that the trust, it has been is still a sensitive and soft spot in AI adoption. Yeah, it's a huge issue.
So Sue also mentioned, I believe she said, I believe all these health monitoring devices, which can lead to persons aging in place due to the data that are being transmitted. And so all of these, if data are transmitted that's meaningful, can really facilitate aging in place, as you sort of mentioned towards the beginning of your talk.
Yeah, definitely. Like I think that there are opportunities to strengthen support that they receive, and again, they can support their mobility and mentation and aging in place. But the idea is not just getting more data; it's getting meaningful data. And I think these days there's quite a lot of interest in fault prevention in the and there are like depth camera sensors, like wearable devices, and so that's generate an enormous amount of data. but also they may main sensitive, like main issues like false positive, like and what happens when you when a false positive happen comes, like how
I can
this.
tell you the fire department tore down my mother's door when they got some false fall information.
uh
she
yeah.
dropped she dropped her sensor into her purse. She wasn't even at home. And so it picked it up dropping,
Oh, they really do not drop it.
and then
Oh
they
no.
tore down her door. Ah, anyway,
Oh,
so rather than I'm not hearing from anybody about my question, so I'm going to pose to you: if somebody is working with an older adult and they do bring up, I've got this app or I've got this thing on my watch and it's telling me this, I want to, act on that. What do I do? How would the professional sort of get, where would they go, or what would you recommend for them to get information and understand whether this is useful or just a a fun app for people to play with?
well, so first of all, like this is important first steps. Like if they engage in conversation and they then bring it up in a discussion, because that's the first steps. But it's also I often engage in the discussion and sharing like what's my take, and again like it's kind of reflecting on clear, and reminds me of the time where like there is app for everything, and there are these claims and the so I try like to encourage women saying like what we know, what we don't know, and taking everything with a grain of salt. That's often the claims are kind of exaggerated, and probably science is still lagging behind. So I wouldn't blindly trust like whatever recommendations or whatever new tools or whatever headlines you see. So I would have a meaningful discussion about that, and a kind of a grounding it in as much as you can in the science.
Sue mentions, I again believe that all data has to be interpreted and related to the individual person, that data left without analysis means nothing, which is kind of the point that you're bringing up.
Yeah. So I often we often like even in our research studies, like when we use some of the wearable devices, and then the off-the-shelf devices, and then we get a new feature is pushed, and then you deal with like what it means for that individual, and that's we can again like relate back, saying like what data has been collected, and what it means or what it does not mean, and again that's I I it's not discarding this discussion, but engaging in meaningful discussion and reflecting from the clinical experience.
Well, and I like the idea that it creates an opportunity for the healthcare professional to think about what is concerning for this person, and then engage in discussion about that, and thinking about assessing it, and referrals, and making recommendations. And it's a great opportunity, even if the person is not really familiar with the technology or the app or whatever.
Well, it means like there's a interest in understanding kind of, and there's interest in the either digital literacy or health literacy or AI literacy. So trying kind of interfacing where they are, and giving them tools to understand what it means.
Well, Dr. Zaslavsky, thank you so much. This has been a really nice cap to the geriatric series, a very thoughtful and insightful perspective. So thank you. Really appreciate the information. Everyone, thank you for your participation in the series this winter, and I look forward to seeing many of you this spring. I did post in the chat the link that you can register for. You should be getting registration details also through email. And have a good spring break. Thank you very much.
Thanks a lot. Thank you for having me.